I'm going to talk about nursing excellence in HIV care. I wasn't given a brief, so I've just sort of gone with what I think it should be. So I just wanted to look at nursing, and I want the aims and objectives of the talk really are to look at, what we do as HIV nurses and what we need to do to survive. But also I want to look at some of our strengths and develop some of our weaknesses. So I thought, why did I become a nurse? So I remember when I was about 14, sitting in a careers interview at school, and because I was tall and big, I think, and I lived in the middle of the country, there was a talk of, farming, not really me, being a policeman. And I just said I want to work with people, and they said, well, what about nursing? So I hadn't really thought about it, but all I knew is that the sight of blood made me feel really faint, so I wasn't too really keen on that. But I sort of went with it, and it was like, well, this will do, and it's maybe if I get a nursing qualification, I can travel around the world and do lots of things. So I've travelled from Hull down to London, so that's my travelling around the world. So I was looking at what it was to be a nurse. So I was a child of the 70s, and these are my visions of being a nurse. A lot of it was Carry On films. I thought they might ban me if I had the picture of Barbara Windsor looking a bit too sexy. But Carry On Nurse, Carry On Matron, those were my role models. And I think we had things like angels and then no angels. And so the images of nursing, which were predominantly female, and I was always sort of known as the male nurse, and I'm sure a lot of the male nurses in the room, that was our title. But the images of nursing was always female, and it was always, I felt at the time, like a soft thing to do. Surely, so you're going to be trained to be a doctor at the end of this? No, I'm going to be a nurse. And I think there was very little aspiration. But nursing has changed, and nursing now has changed to be a profession which is on par with our medical colleagues. But I want to look at what's happening with nursing at the moment. Has anyone heard of the Nursing Now campaign? I did a talk at the International AIDS in Amsterdam with the American nurses, and she said, we've got a speaker from Nursing Now who's coming along, and she was saying how fantastic it was, and I was like, I've never heard of it. And it's sort of based in London, and I'd never heard of it. And a very nice woman came and spoke about it. But there was a report by the International Council of Nurses and World Health Organization, which looked at the role of the nurse and strengthening the role of the nurse, but also globally, the need for nurses, the need for people to become nurses. And they looked at what they called the triple impact of nursing, which was to provide better health, stronger economies, and greater gender equality. But they also looked at the need for, globally, for us to raise the profile of nursing and to make it central to health policy. And I think it was interesting, we talked about this at the International AIDS Symposium, and then we looked at the programme for the whole of the symposium. There was one nurse in one session through the whole of 5 days. We were pushed to a pre-conference study day. So it's interesting, we're looking at raising the profile of nurses, yet nurses don't have a very high profile. To enable nurses to work to their full potential, and nurses are too often not permitted to and enabled to fulfill our potential. And whether that's through culture, regulation, law, or other barriers. And to collect and disseminate evidence for the impact of nursing and access to quality and care. And I think, doctors are great at doing research, nurses aren't, because we don't really get time to do that. But they also looked at the unique contributions of nursing, and they looked at hands-on care, that they were person-centred, and that we have lots of skills and knowledge. It's interesting, I was at a talk recently where a doctor was talking about holistic care and treating the person as an individual and individualised patient care, and how wonderful it is to know a lot about the patients that we look after. And throughout the whole of the talk, I'm sitting with a nurse colleague of mine going, this is like day one nurse training. So it's So I think when we look at, our skills, it's important to know that I think from a person point of view, I think we're way ahead of our colleagues. So the nursing timeline. So at the beginning of the AIDS epidemic, I think nurses were there at the forefront. We were the ones who were dealing with people who were predominantly younger people who were dying. We were the ones who were there when they took their last breaths. We were the one who performed who looked after the bodies and took them down to the mortuary. We were the ones who were there to comfort their families and friends. And then medication came along, and it's nurses who were there to provide adherence support. We were the ones to talk them through complicated regimes. We were the ones to talk to them about diet, about when to take their medication, supporting them with working out a routine for their day. And then to today, where the people who are monitoring long-term conditions, it's nurses who are leading the way with annual reviews, it's nurses who are looking at long-term health. I think it's HIV nurses who are having to become HIV generalists now. So the profile of the people that we're looking after, this is from NHS England, and it's looking at, and also Public Health England, is looking at the patients that we look after. So they estimate that we have 7% of new patients who are newly diagnosed, that we have 80% of our cohort who are stable, and then we have a complex patient group, around about 13%. My job in the community is to look after predominantly complex patients. And I can tell you now it's more than 13%, and I can also tell you that that list is not complex. Pregnancy is very rarely complex these days. Chronic liver disease we manage quite well. I would say that we need to look at this list and change it. But the role of the nurse in HIV is many. So we are the ones who provide HIV testing and diagnosis. We do the initial support and discussions. Nurses can now prescribe, and we manage antiretroviral therapy and as well as adherence support. We monitor and support and evaluate ongoing health. So as Breda was saying, which is fantastic, it was her that recognised these things that were going on, and it's her insight that changed that case. We're there for complex case management. We're looking at long-term health assessment, and we're the ones who provide the annual review. We do lots of joint management of palliative and terminal care, so we're not just handing over our patients to another team. We're the ones who encourage our patients with self-management and to become expert patients. And I think we're really, the one thing that's kept me going in this job is working with a really skilled, knowledgeable group of people who I look after, who will tell me the latest news and will give me little snippets of information and will challenge me on a daily basis. But we're also there for social care. We provide rehabilitation, we provide emotional support, etc., etc., etc. And underpinning all of this is our NMC: care, compassion, competence, courage, communication, and commitment. So what shapes excellence in HIV care? Well, obviously we have a code of conduct from the Nursing and Midwifery Council. And I thought, now's my chance to big up what we do at NIVNA. So we've provided advanced nursing practice guidance. We have nursing competencies. So we have a set of guidance and documents that will support nurses to develop their role. And also we have the British HIV Association Standards of Care. So there are things that will shape the way that we work, but we're also shaped by our experience. Managers, good or bad. Our peers, we work with really great nurses. Our patients, I think, are the ones who really shape what we do. But also we're shaped by our mistakes. We see good practice and we learn from good practice, but also I think we learn from saying the wrong thing, doing the wrong thing. We're shaped by our education. Now, I trained in the late 80s. I still don't have a degree. I'm digging my heels in about doing a master's. But, I think nurses have moved on and on. And there is a huge debate now around, the role of experience and the role of education. But nurses now were initially educated to degree level, masters, and we have nurses doing PhDs. We have conferences, we have ad hoc training sessions, we have best practice guidance, we have continuing professional development. And they all inform how we work. But we're also shaped by life. We're shaped by the things that happen to us on a daily basis. We're shaped by little things that are going on. We're shaped by politics. We're shaped by anger. We're shaped by good times and bad times. So I wanted to look at how we define excellence. So I think we've had to define what we do. I don't think there's anybody out there who's saying, what we're doing is great. NIVNA as an organisation, we put together various pieces of work. We've done, and we work with other nurses to look at, what do we need to push nursing forward? So as well as advanced nursing practice, we now have models of community nursing. We have a fantastic document looking at the annual health review for people living with HIV. And we have a journal, and it's the only one in the UK. It's a really good one in America that the American nurses do, but it goes way over my head. So I think when I was putting this together, I want to look at what we do as nurses, and we do a fantastic job, but we don't often sing about it. So I think it's sometimes when we're looking at financial pressures, and we can sometimes feel that when it says the NHS has got to save £20 billion, I think a lot of nurses just do this. Let's just keep our heads down. Let's not say too much. Let's hope they don't take too many staff away from our clinics. But I think sometimes it's nurses who feel that the axe is swinging above their head. So I think it's important for nurses that they plan and carry out their own evaluation of their service. Even if we don't have time, it's just to sit down with a group of other people and just say, what can we do? How can we prove what we're doing? How do you demonstrate how you spend your time? We've probably all done lots of time and motion studies, which, in their own way, are either a good or bad thing. We need to look at what we're doing, and is it truly a specialism? Are we specialist HIV nurses, or can anybody else do our job? I think we are. I think nobody else can do our job. I think people, when you get a general nurse who comes to work, or to maybe do a day walking around with me in the community or working in a clinic to see what happens, if you throw them some of the things that we deal with on a daily basis, they either have a passion and think, that's what I want to do, or they go, oh my God, I can never do that. But how unique is our role, and can somebody junior do the same thing? And I think this is sometimes something that we look at all the time. Why are you, as a Band 7, doing this? Can a Band 5 do it? But I don't think we do ourselves any service at all, and sometimes it's about looking at the language that we use. Doctors are very skilled at talking about what they do and what their role is, and I think nurses, we need to catch up. So you'll hear people say, I care for people with HIV, or I manage and support the continuing care of people with HIV. Which one sounds the more professional? Well, it's I manage and support continuing care. I think sometimes we'll say, nurses are, we're the angels, we're the people who do the nice things, we're the ones who hold the hands. But by saying you're a caring or carer, a patient said to me the other day, said, so you're my support carer? I said, I'm your clinical nurse specialist. So you care for people, but you still care for people, but you care for them by assessing and monitoring and responding to their ongoing and HIV needs. And sometimes you can call this vigilance or rescue work. So we are vigilant. We do see somebody holistically. When I go and visit somebody at home, it's just not about me sitting down going, okay, I've come to talk to you about adherence. It's me scanning their room, seeing where they store their medication, seeing how they take their drugs on a daily basis, seeing what else is going on, who else is in the house with them, noticing whether or not underneath the table is a 2-litre bottle of vodka that they've not told anybody about, or there's evidence of drug use. We're responsive to need. We refer to GP and community services, which may prevent unplanned hospital admission. So I think we're very good at looking at what's going on, who else can deal with this, do we need to refer on to other people? And think about how you describe your role and what you do and don't do. And it's very easy for me to go, oh, what have you done this afternoon? Well, I've done some notes, I've made a few phone calls. Well, it's not just about making a few phone calls, it's about saying I've had 5 conversations with somebody's doctor about their care, somebody's social worker about somebody's benefits, the housing worker about sorting out their housing needs. I've talked to somebody's family about what's going on with the situation. I've talked to somebody about you equals you, or I've had a quick ad hoc conversation about PrEP with somebody's partner. But how do we demonstrate the effectiveness? How do we justify our roles? I think we're having to do this all the time. But it's important, I think, sometimes to think it can feel a bit overwhelming. You know, I don't have time to do an audit. But maybe what you need to do is just to ask somebody in your IT system, going, actually, can we collect this data? How do we collect what we're doing? How can I look at how I'm being effective? I think case studies are very effective. I think Breda showed fantastically how she was very effective in that case. And I think sometimes we would downplay our role in that. We can do an economic assessment. So I learned very well a few years ago working with the RCN. I did an economic assessment of my role and said, if you take this role away, what effect will this have on the patients that I look after? So if I was no longer here, so if you were no longer in your clinic, no longer doing your job, what effect does that have? And it's about thinking critically about all the things that you do in a day. The little talks, the quick phone calls, they all add up to effective case management. So I just wanted to look at some of the do's and don'ts of adding value. We've all been told, you know, you do a great job, but what else can you do? So I think it's about saying don't be shy, and it's very easy to say, oh, it's not just me, it's the whole team. But it is just you. Sometimes it is you. You're the person who will go, oh, I'll do that. I'll make those phone calls. I'll sort out that appointment. I'll give them a ring and do this. And if it's you who's doing it. Be an HIV specialist, but add your value by being a generalist. And I think we're having to do this more and more with an aging population. It's not just about me going into somebody's house and monitoring their HIV antiretroviral use and making sure that they're adherent. It's about me checking up everything else that they're taking, looking at my phone, seeing if there are interactions with some of the medications that their GP's given them, or noticing that they've just suddenly gone to Holland and Barrett and bought a whole shed load of things, and then going through a very complex list, going, okay, right, is there interactions with this? What are you taking this for? Why do you need to take this? I think we need to fight for professional development and training. I mean, hopefully we've all got a study day to come here today, but some of you may be here in your own time. We need to show off a bit. We need to write about what we do, whether it's a case study or a service development or you present at conference. Sometimes we'll think we don't have time to do this, but I think it's important because, like I said, our doctor colleagues are very good. Beaver has thousands and thousands of posters. International AIDS had thousands of posters going on. NIVNA, we have about 20. You know, we have very few abstracts done by nurses. So I think it's important that we look at shouting about what we do, telling other people, saying this is the impact that we have. We need to use our language appropriately. You case manage, you advise, you monitor, you assess, you evaluate, and lose the words that downplay what we do. So it's not just about going, oh, I just make a few phone calls, oh, I just do care, oh, I just sat down and had a chat. And don't assume that your manager understands the full extent of what you do. I won't name names, but I probably have had to explain to the person who manages my role exactly what I do, and they really have no clue. If you actually sit down and say, this is what you do on a daily basis, this is what I do on a day-to-day basis with my patient, they sometimes sit there going, how do you get the time to do all of that? So it's about being proud to be a nurse. I'm not great with American people, but the American nurses were fantastic at international aids because every time one of them stood up at a mic, they have it robotically drilled into the head to go, "Hello, my name's Shaun and I am a nurse." And that's what you do. You just say, "I'm a nurse," all the time. Because they're very clear about raising the presence of nurses. If you just go to the mic and go, "Can I just ask a question?" and you don't say what you do, then people don't know that nurses exist. We need to collect quality data about what we do, but think about the small stuff. Think about everything you do on a daily basis. Every little phone call that you may think is insignificant may make a big impact. We need to get involved. Is there nurse involvement in all areas of care? And where is the nurse voice? And I think sometimes this is highlighted at other conferences. It's great that we're having this today. It's great that we're having a conference for nurses and pharmacists. It's great that I can stand up here and talk. But not every conference has nurse representation. Not every conference has patient representation. I think it's important that we all have a voice. We need to discuss and write about what we do. So I've said this before, does everyone you work with know what you do? And don't assume that they do. I mean, this is great coming from me because I think probably in my trust, people still don't know what I do because I don't really come and talk to people. But I think it's important to say, look, I think people go, "Oh, you're a nurse, so I think you do this, this, and this." But actually, if you did a presentation and said, on a day-to-day basis, as a manager of a clinic or as a nurse lead, this is what I do, people will be astounded because you do so much more and then you look after your patient cohort. And accept praise. We're terrible. We have to do a revalidation, and part of that revalidation is talking about some of the praise you may get, and it's a really awful process. I'll go, "Oh, I got a thank you card," or "I got a bottle of wine at Christmas," but that's actually a person saying to me, "I value what you do for me." But you don't want to see it like that. It's like, it's just part of what I do. And I want to look quickly just at future opportunities. So we do have nurse-led clinics. We do have nurse-led services. I went to an advanced nurse practice meeting a few weeks ago, and even though we do have these, a lot of the nurses were saying, "Yeah, we have a clinic, but nobody's booked into it." And it's important that we get people into those clinics. But we do annual reviews. There are nurses who are doing annual review clinics. I think we can look after complex care. I think because we see people holistically, it's a really great thing for us to do. And if we don't do it, we should maybe sit in with our doctor colleagues and sit down and offer other advice. Look at social complexity, look at the psychological complexities. Look at the economic complexities that people are going through. We need to innovate. I think we're great at developing and leading new services. I'm lucky to work at 56 Dean Street, and I can see all the time nurses who go, "I've got an interest in this," and the manager goes, "Run with it. Put me together a proposal and let's see what we can do." We need to provide and present evidence, we need to publish, and we need to attend conferences and talk. We started at Niven last year for the first time a case study session, and I think it went down really well. And I think that was just stealing from our Beaver colleagues because they present case studies all the time and we don't do that. We do work at nurse practitioner level, but we need more formal training. We need to be given the time and the money to do this. It's okay if your manager says, "But you've had 6 days study leave," but you know that your course is 200 hours worth of study, so you're providing 140 hours of your own time to do it. It should be the norm. The NMC are looking at education standards, and the results should be out soon. And we need to look at developing the next generation of HIV nurses. We need to look at future training and opportunities for students and newly qualified nurses. I'm 50 now, I'm hopefully going to be retiring in the next 10 years, but who's going to take over when we go? And there are a lot of people of a similar age. We've all worked in HIV for a long time. We're all going to go soon. Not up to heaven, but over to a nice little house somewhere, maybe in Europe if we can escape. And I just want to look quickly for why HIV nursing? Why did I choose to work in HIV? Well, it's ever-changing. I think no other area of care has developed so rapidly over the past 30 years. And nurses have led the way at being responsive and flexible. I've had to learn to change from being a palliative care and terminal care nurse to being an adherence nurse, to monitoring self-management, to providing training, to working with patients. It's changed completely. It's the thrill of it. Every day is different. Every patient is unique. There's no pathway the same. So it's okay, we're looking at all of the side effects and interactions with drugs, but every patient that we look after will have a different interaction. So unlike chemotherapy, where you can say, well, actually, maybe on day 9, you'll start losing your hair, you'll feel sick after the first 2 sessions. With an antiretroviral drug, you're going, you may get this, you may get this, you may not get anything, you may get everything. And I think from diagnosis to treatment response, there are daily challenges. Somebody will just pop into your office, or you'll make a call, or you'll go to see somebody at home, and things are happening. It's a nurse-led service. We're autonomous practitioners. We're knowledgeable and skilled in areas usually shied away from. So we're the ones who will talk quite happily about sex, sexuality, gender, drug and alcohol use, death and dying. We have very sick senses of humour, I find. And I think we need to find your passion and to run with it. And I think that's the good thing about working with an HIV. It's allowed me, it's allowed my colleagues to find a passion in what they're doing and to work with that. And that's me. Thank you.